Thank you, Dr. Prince, for that very nice introduction. So thank you. I'd like to thank the program committee and the Asian Endocrine Surgery for having me here in Delhi. It's really a pleasure to be here at the meeting. And my condolences to Dr. Ime, and so I'm sorry you have to listen to me this afternoon, but I'm going to try to talk a little bit about adrenocortical carcinoma and the role of prophylactic lymphadenectomy. In the next 20 minutes or so, I hope to review the literature on lymphadenectomy in patients with adrenal cancer, talk about some of the strengths and limitations of these studies, and then maybe talk about some future directions for identifying the role of a prophylactic lymphadenectomy. So as we all know, the incidence of adrenocortical carcinoma is only 1 to 2 per million per year, so it is a rare disease, and it's associated with a very poor prognosis because of the high rates of extraadrenal disease by the time patients present and the very high recurrence rates. There are very few systemic therapies, which emphasizes the importance of the initial surgical management. And the controversies that we all know about are the ideas of laparoscopic versus open adrenalectomy, and then the role of lymphadenectomy at the time of initial surgery, which is what I'm going to talk about today. So the staging systems are the two most common, being the American Joint Committee on Cancer staging system for adrenal cancer, and this is the 7th edition that you see up here, as well as the NSAT, so the European Network for the Study of Adrenal Tumors. And for stage 1 and 2 tumors, they're pretty much the same. If you have a T1 or a T2 tumor, no nodal metastases and no distant metastases. And where they differ a little bit is with the stage 3 and 4 tumors. So as you can see, with NSAT, as soon as you have any distant, only if you have distant metastases are you going to be stage 4, whereas with the AJCC staging, you can have a T3 tumor and be a stage 4. So what does that mean in terms of lymph node dissection for adrenal cancer? So lymph node drainage of the adrenal glands. So we typically talk about the celiac lymph nodes, the renal hilum lymph nodes, and the para-aortic or the paracable lymph nodes. And of interest in adrenal surgery, so the lymph nodes on the right adrenal are going to stay on the right side of the aorta, the left adrenal on the left side of the aorta. And so that helps you compartmentalize the extent of lymphadenectomy when you're thinking about adrenalectomy. So the recommendations from the 2016 European Society of Endocrine Surgery and NSAT were that routine local regional lymphadenectomy should be performed for suspected or proven adrenal cancer, and that this should include the periadrenal and renal hilum lymph nodes. There is very strong agreement by the two groups, but as you can see, the evidence level was low for this. They also recommended that you remove the celiac axis, superior mesenteric artery, para-aortic nodes, and or paracable lymphadenectomy ipsilateral to the tumor, that it be considered. And here there was low agreement among the panel with very low evidence. And so why is there such bad evidence for the extent of lymphadenectomy? So this was a study from about 10 years ago. It was from almost 4,000 patients in the National Cancer Database, which is the database that we heard Dr. Prince speak about this morning. And so of these patients with adrenal cancer, about 75% or to 3,000 patients underwent surgery. Lymph nodes were examined in 716 patients, and there were nodal metastases in 190, or just over 25% of these patients. And if you can see in the graph here, those with nodal metastases in this Kaplan-Meier curve had a much higher rate of mortality, much lower survival. And so the authors of this study looked at the differences at 5 years of relative survival and median survival. And when you look at nodal metastases, those patients who had nodal metastases obviously had lower rates of survival at 5 years, and the median survival was significantly shorter. I think one of the criticisms of the study, though, is that this was just a dichotomous. You either had positive nodes or negative nodes. It didn't talk about the extent of lymphadenectomy or the number of metastatic nodes or the number of nodes resected at the time of surgery. This study from the German Adrenocortical Carcinoma study group consisted of 283 patients, all of whom were NSAT stages 1 through 3, had an R0 resection and had at least 6 months of follow-up. And they very specifically defined their lymph node dissection as at least 5 excised lymph nodes. The primary endpoint of this study was disease-specific survival in patients with or without intended lymph node dissection, and they also looked at recurrence-free survival. So of this study, 47, or only about 17% of patients underwent lymph node dissection by their definition of at least 5 excised lymph nodes. And from this, 9% had lymph node metastases. And interestingly, those 25 patients, 12 of them were from patients who underwent what was an intended lymph node dissection, and 13 were from those who did not undergo an intentional lymph node dissection and merely had lymph nodes excised at the time of their adrenalectomy. When they looked at their outcomes, so this is no intended lymph node dissection versus lymph node dissection, and those who had a lymph node dissection had larger tumors, were a higher stage, more positive lymph nodes by percentage, and were more likely to have had a multivisceral resection. When you then look at the data based on whether or not there was actually metastatic lymph nodes identified on the pathology, those with metastatic lymph nodes had a shorter median time to recurrence and a shorter disease-specific survival, although the latter was not statistically significant. So based on this study, again, this is looking at recurrence-free survival for those patients who underwent lymph node dissection or not, and you can see that there was a significant difference. I think, so based on this study, the authors advocated a prophylactic lymphadenectomy, saying that it allowed for improved tumor staging and improved prognosis for patients. I think, again, some of the issues surrounding this particular study are that we don't really know what the effect of a lymphadenectomy was. So the authors chose a relatively arbitrary threshold of 5 lymph nodes as their definition of an intended lymphadenectomy. And as I mentioned, there was almost an equal number of patients with lymph node metastases between those who had an intended lymph node dissection versus those who did not. And so was the better survival in those lymphadenectomy patients secondary to more complete tumor resection because you knew you're going to be more aggressive for an oncologic outcome? And I think that's, for this study, an unanswered question. And a different study from a large administrative database in the United States is the National Cancer Institute Surveillance, Epidemiology, and End Results, or the SEER database. And so this study from the group at NIH defined a lymphadenectomy as greater than or equal to 4 lymph nodes removed. And so they had about 1,500 adult patients, and the rate of lymph node metastases was just about 13%. And so the median number of lymph nodes resected was 0, and there was no lymph nodes removed in 84% of patients. 800 patients had available data on the number of lymph nodes removed, and it's about 67 or 8% underwent what they defined as a lymphadenectomy. And there was no difference in the rate of metastases between those who had 1 to 3 lymph nodes removed versus those who had greater than or equal to 4 lymph nodes removed. And so you can see those percentages there. So what did they look at? So they looked at the patients with the lymph node metastases, and they did find that it was more associated with a poorly or undifferentiated adrenal cancer and with locally advanced tumor, but it was not associated with tumor size. And the disease-related mortality was also associated with regional lymph node metastasis, also associated with age, so at more advanced age, more locally advanced tumors, as you might expect, and certainly distant metastasis. So these authors then concluded that lymphadenectomy, so just performing a lymph node dissection, was not actually associated with a longer disease-specific survival on univariate analysis. But when you put this study together with the previous German adrenocortical carcinoma study, they did find some disease-specific survival differences, and so the basic conclusion from these 2 studies was that you should consider lymphadenectomy in patients with advanced adrenal cancers. But the limitations to both these studies, and I mentioned some of them already, is that the definition of a lymphadenectomy or the intention to perform a lymphadenectomy still remains unclear and a little bit arbitrary. For SEER, for this latter study, it does not include data on recurrence for all the years that were included in the study, and there's probably a patient selection bias in terms of who underwent surgery for adrenal cancer and how aggressive that surgery was. So our institution was part of a research collaborative of 13 institutions in the United States, all for adrenal cancer. So we looked at whether or not there was a therapeutic benefit for lymphadenectomy. So it's 120 of the 256 patients in the cohort met our study inclusion criteria, which were age greater than 18 years, a known intent for lymphadenectomy, R0 resection, and no distant metastases. And so because this was a limited cohort, and because this was specifically from 13 centers, we were able to get the operative reports and review them, and so the patients were able to be grouped based on the surgeon's reported effort to perform the lymphadenectomy, which is a little bit different than those large administrative databases. So in this cohort, just about a quarter of the patients underwent an intended lymphadenectomy. This was more often in larger tumors and more often when there were suspicious lymph nodes on imaging, as you might expect. Of these 32 patients, 19, or about 60%, had greater than or equal to 5 lymph nodes examined by the pathologist, and 3 reported no lymph nodes in the specimen. So that was about 9%. And this picture just shows the distribution of resected nodes. So the number of patients is on the y-axis, and the total number of lymph nodes resected is on the x-axis. And so you can see here where the metastatic lymph nodes were removed from. So most often, excluding the port hepatis, because that was only an N01, most often from either retroperitoneum or renal hilum, as you might expect. And we looked at the overall survival stratified by the performance of lymphadenectomy. And so you can see the blue line in the top figure shows that if you did not have a lymphadenectomy, you had poorer survival than if you had a lymphadenectomy. And again, this was shown on multivariate analysis. So lymphadenectomy was associated with overall survival at 5 years, 76% versus 59%, which is statistically significant. Of course, this study also had limitations. It's a retrospective series, and again, there were very few lymph nodes harvested overall, despite some of the intents for lymphadenectomy. So, what do we conclude from this? So, local regional lymph node metastasis is shown to be associated with decreased time to recurrence and perhaps decreased disease-specific survival in patients with adrenocortical carcinoma. But there's data conflicting on the benefit of lymphadenectomy. So how do we reconcile this apparent discrepancy between the benefit of a lymphadenectomy and what happens when you know that you have lymph node metastasis? And I think there's a few ways to think about this. So first, I think retrospective data, as we all know, it's flawed. Sometimes it's the best that we have, especially with rare diseases, but it is flawed. And so the intention to perform the lymphadenectomy is often unknown, and the definition of lymphadenectomy is based on pathological data. So it might happen to be just what was counted by the pathologist and what was reported by the pathologist. There's also a selection bias for a more aggressive surgical resection, because again, adrenal cancer often presents late, and so there are some patients who never quite probably make it to surgery. And it remains unclear if the benefit of an intentional lymphadenectomy for adrenocortical carcinoma exists, because the level of evidence is relatively low, and there's a paucity of lymph nodes in the area surrounding the adrenal gland. So what are next steps that we can take? So I think that there's the MD Anderson group in Texas published a couple of years ago the idea of the borderline resectable adrenocortical carcinoma. And so I think in the future we have to think about the role of neoadjuvant therapy in these borderline resectable adrenal cancers and how that might affect regional lymphadenopathy and ultimately our ability to resect these lymph nodes and what that might be for patient survival and disease recurrence rates. Also, what is the effect of postoperative radiation to the adrenal bed to minimize recurrence and improve survival? So we know that there's not a lot of lymph nodes involved, so how might postoperative radiation improve survival even if there's not a lot of lymph nodes resected? And then lastly, I think there's a role for further prospective studies to better identify the intent of lymph node dissection at the time of surgery and to define the optimal nodal basins for lymphadenectomy and the threshold number of resected lymph nodes. And I think, again, as we've talked already about today at this meeting, the role of societies such as this, where there's a large cohort of patients, a lot of institutions involved and interested, that we can do some of these studies or at least talk about how that might be achieved for particularly these rare diseases. So thank you very much for your attention this afternoon. This is our group in Milwaukee. I'd be happy to take any questions.